Welcome to the Working Smarter podcast. Concise conversations about legal and regulatory topics in healthcare that are always engaging and sometimes funny, with the goal of helping you work smarter.
Hi, welcome to Working Smarter. I'm Wendy Rubas, General Counsel of VillageMD, and I'm here today with two of our new Working Smarter co-hosts. I'm so thrilled to have them. Guys, why don't you introduce yourselves?
Hi, my name is Emily Guthrie. I am a legal analyst here at VillageMD, and I'm super excited to be here today.
Hello, everyone. My name is Genelle Nkwocha. I'm also a legal analyst here with VillageMD. Also very excited to be here and talk about this today.
Yeah, big format change today.
Major format change, which, as we know, came about because we had a long, typical legal department meeting, all day, no breaks. And afterwards, we had a short little, happy hour, at which time Genelle and Emily gave me some feedback about our format. And they are much cooler than me. I could tell immediately. So that's what you get for feedback. Now you're a host.
No, I'm super excited. I think that always been a fan of the podcast. Y'all do great work, but I think just getting on video and getting more personal, I'm excited about the changes and excited to see where it all goes.
Well, I am very afraid of video. Everybody knows that. That's why I love avatars. But my daughter does this thing with filters, or on Instagram, or is it Snapchat, one of them. And there was some filters that you looked better.
No, you look great, Wendy.
But then there was other ones that made me look terrible, like a man or like a groundhog. So, but I understand we don't have filter capabilities, so unfortunately.
No, and there's a lot with those filters. I was hearing about some big lawsuit that was going on with Snapchat and everything about their filters and everything, all about data privacy or something. Yeah, it's apparently a really big situation that's going on. All of those things. There's so much interesting going on with data privacy and everything. And yeah, it's super interesting.
So they're using data from the filter? Like you use a filter, now they know what your groceries are.
Yeah, there's a lot of interest keys about it, but who's to say?
I think honestly, most of it has to attribute to the fact that back in 2015, Facebook had a class action lawsuit because they were tracking a lot of their users.
Yeah.
Their data tracking like that. So it's very interesting that it's now coming up nowadays. Especially because now,
it's not better. Well, maybe we should do another episode on data privacy.
Yeah.
That would be cool.
Yeah, I like that.
And if we do that, can we use filters or no?
We can experiment.
We can say, let's see if using this filter, we end up with a lawsuit for our privacy. That might be an interesting podcast.
Yeah. Yeah. A live experiment.
Yeah.
Which filters cause.
But I would just tell our listeners and our viewers that I'm much cuter and thinner than this video makes me appear.
You look beautiful, Wendy.
Thank you. I wasn't fishing, but thank you.
So I was in a meeting a couple of days ago, and they were talking about something that I'd never heard of. I think it was called Patient Attribution, and I was wondering if you could tell me a little bit about it.
It's a great question. It's super important. Many people don't understand. We used to do episodes called Look Smarter in Meetings, and people used to secretly tell me, I had no idea what that was before you explained it, which I just think is funny. It's just cultural sometimes in the world. People don't want to admit, but a lot of this is new and it's complicated. So appreciate the question. So the best way I can explain attribution, I'll just give you kind of a thumbnail explanation and then I can give you some more detail. It's I think the best way to explain it is to think about a mechanic. So right now, your car breaks down, you go to the mechanic, they put a new muffler on, you pay them for the muffler. They performed a service, you paid a fee. That's what people call fee for service. You go to the doctor bills for that visit. And for lots of reasons, healthcare, which we can talk about, we're moving into a different environment. People call it population health They call it value-based care. There's lots of different buzzwords. But basically what it would mean for a mechanic is you're paid to keep all of these cars running. So if you were a mechanic, Genelle, and they go, okay, now on, you're going to get paid X dollars a month to keep these cars on the road. And you have to do whatever it takes to keep them on the road. Like, what would be your first question?
Honestly, what kind of cars are you fixing up? How old are these cars? What are the costs attributed to these fixes? These are questions that need to come up.
Yeah, you would need to know, like, what are the cars? Which cars? So if somebody comes in and they go, would you fix my car? You're going to go, is this the car that I'm supposed to be keeping going or not? So that process of telling the mechanic which cars is called attribution. We're attributing certain cars to you, and it's taken a while for this to develop. There is an idea out there, you see, in some models, it's like, you're responsible for cars in this zip code. But that, obviously, you don't even need me to explain. The problems with that is people have their other mechanics they like, and it doesn't work. It's very complicated to do that population-based attribution. And so there's a number of ways that particular car is assigned to that particular mechanic. And that process is called attribution. And it's critically important for the reasons we just said, which is, without it, how does the mechanic know which cars they're responsible for? So applying that to healthcare, I always like to show this slide. And I know you guys told me slides are yesterday a little bit. What I learned is you were a lot more candid during the happy hour. And since that time, you've been a lot more polite, but that's good. But I am going to just show this because I think it's important for, everyone working in healthcare to realize Medicare is, still sort of newish. 1965, it was broken the first day because a bunch of compromises and horse trading and whatever had to happen for it to get passed. And immediately it was payment for charges. So it'd be like, whatever the charge, they got paid. So you can imagine what happened right away. First day, everybody increased their charges. So a series of massive transitions have had to happen to fix it. We went into episodic payment for care, which was mostly inpatient. And that helped stem some of the increases, but it was not that effective, and it's extremely complicated. And it's based on exactly what you said, Genelle, which is, well, number one, what cars are there? And number two, how old are they? What's wrong with them? How are they being used? That's episodes of care kind of payment thinking. But now we're moving into value-based care, which is, if you are proactive, if you are helping avoid expensive hospitalization, if you're helping prevent unnecessary surgery, etc., and that saves a lot of money, that's partly how you get paid. And so that's when you hear people say value-based care, or sometimes people call it population health, that's what they're talking about. It's a total change, not only in payment, but in the model of care. And I came to VillageMD to work with Tim Berry and Clive Fields and Paul Martino, because that's what they're trying to do, is change healthcare towards this better model of care, which I think we would all want to do and want to have for our parents and grandparents.
Right. Yeah. No, that makes complete sense. And it's all really interesting because I feel like we all hear phrases like this all the time. And it's really nice to have someone actually break it down into meaningful bites to understand what it is.
Sometimes it's good to just go back to basics, right?
Yeah. So how does a patient know that they're attributed?
Good question. That's like $1 million question. And the answer is many times they don't. And one of the things about the system that we're in, we had Zeke Emanuel on our podcast last year, and he was partly responsible for the Affordable Care Act. And he said, one of the things he wished that he could have done differently is our system is so complex that it's very hard for people to understand. So some patients are still in the fee-for-service, which is pay the mechanic for the muffler. And if they're in fee-for-service programs, they might fall into like a DCE or an ACO where they do get attributed. Some people are in a program called Medicare Advantage. We used to call it Medicare Part C. And if they're in that, they may have a fee-for-service plan, but they may be in a value-based care plan. And so it's very confusing. Many times people say, like, my mom got this letter from a payer, she doesn't understand. People don't often understand, but there is help available and there are resources and things for people to use, but it is complicated.
Okay, because you were talking about how patient attribution is like related to populations and like geography. So how does that work for methods of like in areas where there's like not a high capture rate of those kinds of things, like unassignable patients in areas where like populations aren't attributed, or patients, how you said, patients might not know that they're attributed?
Well, it's not really based on geography yet. Mm-hmm. But I'm saying you'll hear people talk about that, or like that's kind of something that you conceptually can understand, like, oh, you get this area, but it's not really how it works. It's actually a good segue because it takes us to the next picture we like to use, which is basically explaining how it does work. And there's sort of two ways it works. So there's two ways you get attributed today. And one way is you as a patient can pick your doctor. And you enroll in the plan. Everybody enrolls in a plan every year. And when you do that, you can pick. Or sometimes some payers allow us to give people a form to fill out and go, no, this is my doctor, and I want to be attributed to this doctor. I mean, that has obvious advantages. It's much more patient-centric. It's, there's really good things about that. The other way is that the payer looks to see, who have you seen? What doctor have you seen? And I'm going to assume that doctor is your doctor. That sounds good, right?
Right.
Wrong. I mean, there's so many problems with that, because what if your doctor was out of town or whatever, and you just went and saw another, so like so many times that creates challenges, unexpected. It's like so many things in healthcare. It conceptually makes sense, but there's lots of complexity with that. But that's really how it works. Many times the payer will go, these are your patients. And so there's a lot of work that gets done to go, did they miss any? Is there anybody that we don't see in there? Are there any in here that we don't actually know? We don't know these patients, and so this is like basically like fax machine days here. Have you guys ever used a fax machine? Okay. So like, or this is like when a VCR, you had to like program it to record a show and you didn't just like DVR it. Okay. That was a big thing to like learn how to program to record a show. Like now it's not hard to do that. This is where we are. This is like the VCR days or the fax machine. It's not great. But this is where we are. And I hope if anyone is listening to this that has influence over this, they'll help make this better. There's technology and things that could make this easier and better. Right now, this is difficult. But that's how it works. And as you can understand, for so many reasons, the key behind all of this, not just attribution, but population health, would be to see your doctor. And that's, like Genelle said, you want to know the cars, what condition. How would you know if they don't come in? And that's why you hear people always talking about the importance of seeing our patients.
So our next question is, what about patients that can't come in? What are their choices? What options do they have?
Well, that's why you'll hear people talk about Village Medical at home. And we do have a program that allows us to see patients right in their home. And that's why it's like, imagine if your job is to keep cars on the road. The car that really needs your help can't get to you because it doesn't run, right? And that's the analogy. So that's why we have the at-home program. And what's important to know about our at-home program is you'll hear people talk about home health care. That's not our at-home program. Our at-home program, advanced practice practitioners, some people call them APPs, they actually go into the home. And so do you guys know what APPs? Have you heard of APPs, of course? It might be another episode. We should have our APP leader on to talk to us about that program. Yeah. Let's try to do this. So anyway, the APP, sometimes it's a physician, but a lot of times it's an APP, and they will actually go out into the home, assess the patient, figure out how they're doing, what they need, etc. So that's another reason why it's great to be at VillageMD. It's a fantastic program.
Yeah, especially in the world we're living now with pandemics left and right. It's just absolutely a wonderful thing that we do.
Yeah.
So this method, so just segueing off of what you just said then, so this then, because what you're talking about then just has to deal with patient choice. So does this mean that utilization rates are a lot higher now because there's Village at Home as an option for patients now? Or is it like, or do you see them like as stagnant, or like there's no real difference?
Okay, Genelle, this is why you're a co-host of our show, because you're asking the right questions. So the whole point of, so the answer is yes. The typical lawyer answer, yes and no. I mean, utilization, the idea here is that utilization goes up to see your doctor or your advanced practice provider. Okay. But utilization goes way down for you going to the emergency room, you going to the hospital, because that's super expensive. And it's not like in the emergency room, they're wired to keep you alive, but not well, because they're not going to go, well, here's what you need to do in your life to help this long-term chronic condition. They're going, okay, you didn't have a stroke, so good luck. That's an emergency room, but it's real expensive. And hospitalization is super expensive and somewhat risky. We know about medical error and things in hospitals. So the goal of this is to reduce the total cost of care, but to pay more for primary care and less for the other less effective and more expensive models, if that makes sense.
No, it does. So there is like a downside of financial risk then when you guys utilize those kinds of things, like when those methods are in place for patients.
Well, yeah, we at Village go into a risk program. We're at risk for the entire care. That'd be like the mechanic. You go, okay, listen, you're going to get paid for all these people monthly. But if they need to have a new car, they total their car, you pay for the new car. Like you're at risk for that. That's your problem. So that's kind of the way this works sometimes, is like you're at risk for all their care. And you're taking a chance that we think we can help manage people's care better. And actually that's borne out with not for everyone. Many people have gone into this and not done well. Many people over the years. But at Village, we believe our model, and I think evidence has shown that our model does reduce the cost of care. It is a reliable model of care. So in a sense, just I guess summing up, so it's better care, we believe, but there are new processes that we've had to build just around attribution, which is a process of assigning patients in a population health model to their doctor. So Emily, does that answer your question?
Yes, it does. And you explained that very, very well. I think because a lot of things in healthcare, especially with all of these sorts of things, get very complicated and convoluted, but that made it perfectly clear. Thank you for explaining that.
Well, and we'd love to have, if we have listeners that have other questions like this, where you're sitting in a meeting and you don't understand, you can confidentially tell us, and we'll answer your questions, and we won't attribute the question to you unless you want us to. Or you could come on and ask the question. That would be fine too.
Yeah, because odds are if someone has a question, a lot of other people probably have that exact same question.
Emily, Genelle, thank you so much for new format, which I think was pretty good. And in this new world, how do we sign off now?
I just say you guys can listen to the Working Smarter podcast anywhere that you get your podcasts. Also, don't forget that since we are live now, go and see it live on YouTube and subscribe to the VillageMD channel. And make sure to leave any comments below in the comment section saying anything you'd like to hear us talk about in future episodes.
Awesome. Thanks, you guys, and we'll be back here together sometime soon.
Bye, guys.
Bye, everyone.
Thanks for listening to the Working Smarter podcast. Be sure to subscribe wherever you heard this podcast so you never miss an episode. If you enjoyed today's episode, please leave a rating and a review. We'll see you next time.